And then we'll start with some introductions. Renee, would you mind introducing yourself?
Sure. Renee Bolio Beggs, Indigenous, Jaganashimang, Sibique, Indigenous, Indigo, Sagasqua, Jamaica, Ganunjiba, Migisin, and Dudane. So my birth name is Renee Bolio Banks. My Indian name, or my spirit name is River Woman. I'm from Leech Lake, and I am the Eagle Clan. I've been at NACC for going on 5 years pretty soon, and I'm the elder in residence, and I absolutely love my job. And yeah, my services are open to all. So miigwech for having me. I'm honored.
Miigwech. Nikki?
I'm Nikki Jardina. I'm a public health nurse and I work at NACC. I've been here off and on since 2017, and I am part of this ECHO team.
And I'm Lindsay King-Cooney. I'm the harm reduction coordinator and also coordinate the Midwest Tribal ECHO project. And then we also have Kari Rabi. She's our medical officer and family practice physician. She wasn't able to join us today, but she's also leads the team here. And then I want to welcome Gina Landsee and Kyle Lipinski today. We really appreciate you being here. And you're going to be talking to us about solidarity and recovery within unsheltered communities. So I'll let you take it away.
All right, great. Thank you so much for that great welcome and opening blessing. That was awesome. Kyle and I are excited to be here today. We have a lot of information, so we're going to do our best to get through it. We did cut some stuff from our presentation because last time we did it was 90 minutes, and we're trying to do this in like a half an hour. So we will do what we can. So as Lindsay said, this is solidarity and recovery within unsheltered communities. And so our main focus is really on how to best work with unsheltered folks and how to provide them support around their use and what they're asking for and what they need from us. So a couple of notes on terminology. We try to use the most accepted words and phrases. However, that does change rapidly. And so we use unsheltered, unhoused, and homeless kind of interchangeably throughout this presentation. Same with drug poisoning, overdose, and drug overdose. We want to do a dedication. I know I've been working with the homeless for about 5 years, and Kyle has been doing that for, I think, a little bit longer than me, and she'll say that when we get to her. But we just want to thank the unsheltered individuals who have shared their knowledge, experiences, and lives with us. We could not be prouder to be in community with you. And we want to remind everyone that unsheltered individuals in your neighborhood are still your neighbors. So our agenda is just a brief introduction, some consciousness raising, what unsheltered drug users want and need, and how to best connect and care for unsheltered folks. And finally, introducing myself, and then Kyle will introduce herself. I'm Gina, and I currently work at the Union Gospel Mission Twin Cities, so it's a homeless shelter in St. Paul. And I'm our assistant clinical director here at our men's campus. And these are some things that I've done. We have an overdose prevention program. I think since 2019, we have helped reverse close to like 20 overdoses. So that's 20 lives saved and supported. And then I'm also a community trainer for Steve Rumler Hope Network.
Hello, thanks again for having us. We're so excited to be here. My name is Kyle Lipinski, and I use she, her pronouns. And how I came to this presentation and this work is I've been working with the unsheltered community since 2017. The work that's kind of most relevant to this community presentation is I was a mental health and chemical health counselor at Minnesota Community Care's Health Care for the Homeless program for 3 years. I helped to manage and expand our Safer Use program. And I'm in the middle of, though we have a lot more data from a project that Morgan Weinart and I worked on. The project is called Keeping Each Other Safe, or We Keep Each Other Safe. And it was a grant from the CDC where we partnered with unsheltered drug users to create and design education materials by drug users for drug users. The pamphlet in which we have finalized and been produced is included in the ECHO materials, and please, please, please distribute. And we'll have our contact information at the end. So if you have questions or want to connect more about these projects or with Gina and myself, please do. We would want this to be the start of a conversation. So one of the things that I will say is that I read the tagline for the Mendoza report that came out in 2023 last year. And it was one of the things that was saying that unsheltered folks are more likely to be referred to treatment, but less likely to go, was the tagline that was in a lot of the publications. And it was a situation where I read that and I was immediately like, ugh! Knowing all the barriers and hurdles that our clients have in regards to accessing recovery supports, as well as the very legitimate reasons why a number of our community members in the unsheltered community may not want to go to treatment. And so one of the things that we really started to look at when we read this was, how can we actually create kind of consciousness erasing conversations around this? The other thing that I actually really wanted to say is that when we looked at the homeless mortality report as well, what we're noticing is that the rate of death in terms of death from overdose is 3 times higher in people that experience homelessness in Minnesota than in the general population. And then one of the things that makes it especially relevant for us to continue having this conversation in spaces that serve Native American populations is that Native American populations have a 1.5 times higher rate of death as opposed to other individuals experiencing homelessness, and 5 times rate of death from overdose than the general Minnesota population. And so, you know, the homeless mortality report is something that I think is really important reading, as well as the Mendoza report. And it says that our current services are really just not adequate in supporting and serving this community. And also, how do we actually include their voices in these conversations?
All right, so Kyle already started talking a little bit about drug overdose and racial inequity. And so these numbers are from 2021. New numbers should be coming soon if they aren't already out. But in 2021, American Indian Minnesotans were 10 times as likely to die from a drug overdose than white Minnesotans. And Black Minnesotans were more than 3 times as likely to die from a drug overdose than white Minnesotans. And there's no difference in levels of drug use. It's just there's differences in access to support and just differences in communities and what people have access to. And these numbers are rising. And so like when the numbers so I've been doing these trainings for a long time with this data, but I think it was like 8 times like a year, like in 2020. So the numbers are likely going up. And then the chart on the right is just showing the numbers in a little bit different of a graphic. Some homelessness numbers, we will have new numbers soon because the homelessness study was just done in October of 2023. We don't have numbers yet, but an estimated just around 19,600 Minnesotans experience homelessness. And this is done on like one night in October in 2018. And then overall, like 50,000 people experience homelessness in 2018. That's an increase of about 10% from 2015 to 2018. And lack of housing is a primary barrier for individuals experiencing homelessness. So 56% are unable to obtain or maintain housing. I just saw a study, I didn't put it in here, but like the Twin Cities has one of the highest rates of like single people living alone. So there's just less housing available, and housing is super expensive. And so people are unable, even if they're working, even if they're making somewhat of a living wage, they're unable to afford housing or find housing. And 50% of homeless adults are on the subsidized housing list, which averages about a 12-month wait. So that's a whole year waiting for housing. 77% of homeless adults have multiple experiences with homelessness. So that just means like once you get into the system of homelessness, it's harder to break out. Just simple things like once you're homeless, it's harder to get a job because you may not have access to a shower or transportation or clothes, all the things that we need to be able to be hireable. And then once you have a job, it's hard to maintain a job, those kind of things. 52% had their first homeless experience by age 24. That's a really young age, which likely indicates that those individuals were probably having stuff going on in their childhood, or things really in early adulthood that led to their homelessness. 36% became homeless on or before 18 years old. Almost 6 in 10 homeless adults have experienced physical or sexual violence. Women and those who identify as LGBTQIA2S+ experience violence at a higher rate. So all things that are contributing to people who are experiencing homelessness. 81% of homeless adults have a chronic physical illness. 57% have a serious mental illness. And 24% are diagnosed with both substance use or with substance use disorder, and 50% co-occurring. So substance use, mental health, chronic physical illness. Some more statistics regarding homelessness and race. So African-American and American Indian adults are overrepresented in Minnesota's homeless population. So Minnesota adult population, 6% are Black or African-American, and 37% are homeless. And then for American Indian, 1% is the Minnesota population and 12% in the homeless Minnesota population.
So I think for Gina and I, one of the things that we get asked a lot is, why are people homeless? Or why don't people, why aren't the social services enough? And so I always like to do a little bit of consciousness raising and some questions in terms of helping people understand what the social safety net actually looks like in practice. So, the question that I love asking people is, do you know what year it was when general assistance last experienced an increase in the rate that we help unsheltered individuals or individuals without income in the state of Minnesota by having a guaranteed basic income? What year was the last increase? I think there's some stuff in the chat. So just some things to kind of ground you in terms of what it was like at that time. The federal minimum wage was $3.35, and a 2-bedroom apartment in the Twin Cities was renting for $480 a month. Whew! Imagine if rent was like that right now. The other thing that I like doing when we talk about this is I show this picture of myself because this is how old I was when we had an increase in sort of the social safety net in Minnesota in a substantial way. I also like to think that this is like kind of an absurd photo of me and my twin sister. I think we look like bugs. My mom is always like, "You're so beautiful." I'm like, we're raising a point with this. But for those of you who have a number in your brain, we'll go for it. The year was 1986. So that photo is actually a lie because I was born in December of 86. And so that photo's from 87. But I wasn't even born yet, really, when we had last voted for a legislative change. And so I just really want to name that we are going to see a rate increase in October of 24, which is exciting. It's going to go up from $203 to $350. However, one of the things to think about is if we were keeping up with basic inflation, that general assistance number should actually be $563. And so we really are not keeping up with social safety net support. When we think about the fact that when we said 203, people like kind of 2 individuals on general assistance with a little bit of support could actually rent an apartment potentially for that. Obviously, there would be other things, but that assistance is not keeping up with inflation as well as other points of cost. And so when we're really looking at things like, obviously, evictions, things that are causing homelessness on a systemic level, it's about how much people can afford, where can we actually rent something, and what kind of housing is available. Because I also really want people to think about, it's not just about being housed, it's being housed in a place that actually can be a home that provides some sort of sensory control and a space where people want to live. And so I think one of those things that's really important when we have these conversations is we try to ground it in what's actually happening in the Twin Cities today, which I'm sure most of you know, but I think those numbers sometimes are really helpful. The other thing that I always want to talk to people about is like, oh, the housing wait list, just get on the housing wait list. Well, the average wait for folks in Ramsey County to be housed off of the coordinated entry system is 574 days on the wait list. This is after they've qualified as long-term homelessness, which means either 12 continuous months of being unsheltered or 3 periods of homelessness in the last 4 years. So if we think about that, what we're looking at is really substantial wait lists. So if folks are going into treatment, where are they going after they leave? If it's back to the shelter, what does that mean for their recovery and our ability to truly support them in a comprehensive, holistic way? So one of the things that is important is that the way that Mendoza study was actually talked about is that what they found is 43% of patients experiencing homelessness had attempted and or completed chemical dependency treatment in the past, as opposed to 24% of folks who were not experiencing homelessness. And so what this is that for individuals who were treated on the North Shore for overdose, they were assessing where in the essential health systems, where and what their resources were. And a lot of these folks who were unsheltered had been to treatment in the past and potentially even completed it. The problem was they didn't have anywhere to stay. So when we're talking to people about recovery, I think the biggest problem, and I don't necessarily think so in this community, but as a whole in the state of Minnesota, is it's so much about treatment. Recovery doesn't happen in treatment. It's pretty easy to stay sober in a controlled environment. It's about how do we help someone live a real life in a way that's going to be sustainable and frankly, enjoyable. So in regards to the work that Gina and I do, we see a lot of this amongst our clients. You know, in some of the focus groups that I was running with unsheltered folks who use drugs, these were the quotes that we heard. It seems almost pointless, like treatment. Don't deal with the after. I can graduate, but I still have to go back to where I was. And so this is actually really profound wisdom from our clients. And in some ways, by not going to treatment, they're keeping themselves alive. Because what we've seen is in treatment, people's tolerance can change. And so if there is a return to use, it can increase people's risk of overdose. The other thing that I see a lot of is, why don't they just go to a shelter? Gina and I both have worked in shelters. And the thing that I always like to remind people of is, the Dorothy Day shelter in St. Paul, for those of you who haven't been inside of it, you're sharing a room with 209 of your best friends. And by best friends, I mean perfect strangers who have a whole bunch of different things that are going on with them. The other thing is that the bunks are wide enough that they're quite tight on my shoulders, and I'm not a very wide person. So I just think about what kind of sleep is possible and what kind of sleep aids I as an individual would need in order to sleep in that kind of environment. And Gina can tell you about the world that she inhabits at Union Gospel Mission.
Yeah, so thanks, Kyle. So shelter life is it's not like, like rainbows and unicorns and kittens. It's really challenging and it's really scary for a lot of people. And so this picture on the left here, that is our emergency shelter. And so there can be up to like 50 individuals staying on those cots, which we're talking about camping cots. So not the highest comfort level. And you can imagine like the sounds, the smells, just discomfort, people with varying levels of mental health struggles, people varying levels of substance use at the time. We do our best to keep it safe. And there's a lot that we can't control as far as like property being stolen and just safety in general. And then down here on the right, we have our dorms, which we have one free dorm and one paid dorm, $7 a night or $49 a week, which is cheaper than you can find housing. But again, you're spending time with up to 40 individuals that you likely wouldn't spend time with if you weren't at a shelter. And there's also like coming off the streets. On the streets, there's rules, like there's street rules, but no one can kick you really out of the streets or out of like an encampment. I mean, people do, law enforcement, whatever. But when you come into a shelter, there are rules you have to follow. And that can be really scary for people to like give up what they might have outside of a shelter and then come into the shelter. So how can we help as treatment providers? Like, what can we do to support people who are unsheltered, who are struggling with substance use, mental health? Like, what different things can we offer? So, you know, as Kyle said, like I've been working in this population at the Union Gospel Mission for about 5 years. So I've come up with a lot of things that are helpful to unsheltered folks. So how do we care and connect with them in ways that are meaningful and ways that are helpful? The biggest thing is being person-centered. A lot of times the folks that we serve are used to being ignored. They're used to people being afraid of them, or like backing away from them, or like calling law enforcement on them because they're acting in ways that the general population is not comfortable with. So really meeting people where they are at. Like when someone comes in off the streets, they're like not going to be ready to work on their significant mental health issues. They're not going to be ready to like dive right into treatment. Like they're going to be ready to like eat maybe, or shower, or even just use a bathroom that isn't outside. And so really meeting those basic needs prior to even trying to jump into anything more significant. What I find with the folks I work with is that like the first 6 months of like mental health and substance use treatment is really just like the crisis, like day-to-day stuff. And then if they stay on to do treatment, like therapy longer, then we get to dive into like the more of the trauma work and the things that are more significant. So learning people's names, which depending on where you work, that might be challenging. So I try to know as many people's names here at the shelter as I can, and just greeting them personally is really helpful. Learning their stories, like what brought them here, like what was going on before this. You know, most Americans are like one paycheck away to being homeless or to being in a situation where we like can't pay our bills. And so a lot of people, you know, where life was going okay and then something happened and then here they are. Saying hi, acknowledging presence, and just really listening. A lot of people are going to want to talk about things that don't maybe to us feel like a priority. But they want to talk about their cat who is missing or who has cancer or whatever. Like that's okay, because that's what they need to hear about. Like that's what they want to talk about. And that's how you build relationship, is meeting people where they're at. Luckily, I work at a place where we do not have to bill health insurance. So we're able to listen to kind of whatever people want to say without having to, you know, convince insurance companies that they need therapy or don't need therapy. Recognizing the lens of homelessness, I already kind of hit on that. Basic needs are not available. So those are going to be first priority. And the biggest thing too, I think, is showing up and being consistent. So if you say you're going to do something, do it. Like if you say you're going to fill out a piece of paper for someone or like connect them with someone, make sure you do it, because most unsheltered folks are used to people saying things and then not following through. And if you say you're going to show up, be there, even if it's inconvenient for you or things change. So just really about showing up and being consistent. A couple of action steps. And this is not, you know, people have different beliefs about this first one, as far as like ethically and like what boundaries you're comfortable with, and that's totally okay. But show up for your clients in ways that don't involve your paid position, if that's possible. Even if that's like coming to work like 10 minutes early and spending some time just chit-chatting with people versus like coming in, you know, a minute before you have a meeting and then like running by everyone who wants to talk to you. I have a therapy dog, and so I have to come to work like 20 minutes early if I want to like get into my office on time, because everyone wants to talk to a dog on the way in. Or like volunteering with other organizations that partner with your employer community. So if there's things that are going on at your organization that you can jump in on, great, that's awesome. Go ahead and do that, because it shows people that you care outside of just making a salary. 2, observe, notice, say something, check in. This is something I just made up, but it's just like paying attention. So if, like, I work at a residential essentially because it's a homeless shelter. So I see the same people every day. If you notice someone's acting different, even if they're like, no, I'm totally fine, that's great, but check in with them. And something else that I do is like when someone's leaving the shelter, or actually I try to do it honestly when I first start working with someone, because we never know when someone's going to leave, is asking permission to follow up. So like if you leave the shelter, like if you stop coming to sessions, can I call you and check in? So giving them autonomy over like if this like lady is going to be calling them, and just trying to, you know, be connected in that way. Trying to teach healthy relationship development and healthy goodbyes. So like, how do you connect to people now that you're sober or using less? And how do you say goodbye in a good way? You're not like here or anywhere people are receiving treatment. They're not, you know, a lot of places are court ordered, but like a lot of times they aren't. So if someone can leave by their choice, like how can they say goodbye? Because they're grown-ups, they don't have to sneak out the door in the middle of the night. Like all the people that I work with have keys, you know, to the front, to their rooms or to the doors. And so like, how do you teach, like it's okay to say goodbye, it's okay to check out. Keep an eye on your biases towards homelessness and substance use. Communicate in a way that focuses on respect and autonomy, and then just acknowledging special and hard days in clients' life. So like birthdays, like a lot of people I work with like haven't recognized a birthday in years. Sober dates, some people like sober dates, some people don't. So it's really on what each client likes and appreciates. Death dates, hard seasons, etc. Like just try to figure out like when are things good for your clients and when are they hard for your clients.
So I'm going to talk a little bit about some of the data that Morgan Weinert and I were able to compile from a series of surveys that we conducted with unsheltered folks who use drugs in St. Paul. Individuals were first asked to complete a survey. For participating in the survey, folks got a $5 gift card, and then individuals also were given the opportunity to come to 4 in-depth focus groups that were conducted over the course of an hour. People were provided lunch and given a $20 stipend for their participation. And then finally, we made a pamphlet, which is something that has going to be distributed, and two individuals who identified as drug users were actually part of the pamphlet creation and the editing process to make sure it felt true to them. And the goal of this for us as providers, especially working in a federally qualified health center, was, you know, what are we missing? What are our folks really seeking, especially folks who identify as folks who use drugs? You know, I think one of the things that we miss in a lot of education and training is actually how to be culturally competent in the culture of drug use. It's actually a culture that really cares about members who are part of it. It's a culture in which people really are trying to support themselves. That support might look fundamentally different than ways that we would typically identify support. And it's often different than sort of a lot of the Al-Anon influenced messaging that a lot of people have about substance use disorder. You know, set hard boundaries, cut people off. What we know fundamentally is that a lot of that advice is actually really harmful. Interventions might feel really good for the individuals who are participating and telling someone that they have a problem, but what they do is they cut off that individual from support. So what do our folks really need? So we asked them. And, you know, I think the thing that was fundamentally the most surprising for us when we were analyzing the results was the answer to this question. You know, we asked what other resources would be the most helpful to our folks in terms of feeling supported. You know, mental health support after overdosing or seeing someone overdose, where to get started on Suboxone or methadone, how to get into treatment, easier access to Narcan, easier access to fentanyl strips. You know, I had an idea of what I would expect our clients to actually choose. But the thing they wanted more than anything, both in terms of the initial results we had in 2022, as well as the results of 23, was grief support. You know, I actually got an email today from a series of listservs that I follow around, you know, articles that come out about substance use. And one of the articles that popped up this morning that unfortunately is super relevant is that 40% of Americans now know someone who's overdosed. This is an epidemic of grief. And I think this is something that a lot of service providers, myself included, even as a therapist, had been missing. You know, I was so focused on trying to help people use safely, I forgot to pause and give people space to process. What we know about folks who use drugs is they reverse more overdoses than any other population. They see a lot of their folks struggle. And there's a lot of vicarious trauma that happens with that. And if their drug use is a functional means of coping with grief or trauma, it's something that is going to really perpetuate a cycle. And then one of the other things that actually became apparent when I started talking to a lot of my clients who were working towards recovery is that I had to think about grief in a really fundamentally different way. You know, I had this one client who was continuing to use drugs even though she didn't want to, and she had all these sort of like external forensic focus on her that were really saying you have to stop now or you're going to have consequences. And she kept buying from her healer. And I eventually was able to be like, hey, can we just talk about what is causing you to really feel like you need to support this person? And that was the way I phrased the question. And it turned out that that individual had provided her with free access to substances when she was unsheltered and living on the street. And she identified that as a means of this person protecting her and keeping her alive, because he helped her stay up at night when she was unsafe. And so she was like, I feel obligated to help keep this person housed because I know they're trying to get out the game where they're distributing. And so we had to grieve that ability in some ways for her to support him in the way that he had supported her by changing that relationship, which I think is a really unconventional form of addressing recovery, but is something that we're missing. What are our folks grieving? What are they giving up? And how are we giving space, especially for folks on the street who sometimes are in spaces where they literally are keeping their friends alive because they're the ones who are distributing or using Narcan. So, how is your organization providing space for tributes, grieving, and even looking at unconventional forms of grief and loss? One of the other things that I think is actually really important is that we are making treatment useful. If we are approaching recovery, there's a lot of things that happens in treatment support that's helpful. Sure, learning a coping skill can be helpful in the future. However, a lot of our clients are very much in a space where they think they need things right now. Gina really highlights, if we don't have access to our clients having support in regards to food, water, shelter, safety, how can we work on some of those higher level coping skills when what we know about substance use is it's a really fast, effective way to feel different and potentially better. Now, that's a short-term sort of functionality of it. And so in terms of long-term, what are we doing? The other thing that I think is really important is that, I don't know about you all, but like the world of LADC school is like, motivationally interview that person out of their substance use. Just use MI, it's great. There's actually a lot of evidence that says motivational interviewing is not effective with an unsheltered population. And part of that is because folks might have tons of motivation for change, but if they don't have the structural support and ability to actually make that change, whether it's through income or access to housing or those other basic needs, all of the intentionality they have isn't going to amount to them being able to make progress. And it actually can be something that backfires. So making sure that case management is a huge component of any intervention that we're using. So think about it this way. Are you starting with, hey, I can get you connected to resources? When I was doing street outreach, and Gina and I, this is often something that's the first thing. Can I get you connected to SNAP? Can I sign your MOF for you to get general assistance? Can we start this process by making sure you have access to a coordinated entry assessment, a housing support services referral, an HSS referral, or, a SOAR advocate? In terms of thinking about treatment, is there a way that you can use this as a dual function? So one of the things that I've definitely tried to do with people in the past is, if I have an unsheltered person who's really highly motivated to get treatment for Hep C and go to treatment, is pair the two. Let's get you access to treatment and make sure that you have a safe space with consistent access to food and a safe place for sleeping, so that while you're treating your Hep C and while your body is healing, we can do this at the same time as recovery. So even if there is a slip in the future, what you know is you're addressing your medical health in that moment. One of the other pieces that I think is really important is how are we advocating and supporting folks in addressing all these different sort of systemic barriers? This is something that I ask treatment centers a lot, is how are we actually trying to make sure that housing is going to be a huge part of treatment? What kind of support are we helping people access in terms of finding a job that's not only income, but intellectually stimulating? Really saying people have the right to do work that they feel proud of, not just take the first job you can get. You know, do individuals in your treatment center have access to their own room and their own space? Do they actually address conditions in sober housing to ensure that people are living in spaces that like they want to live? And then also, are you actively keeping up your stipends with the raises in inflation and rent in sober housing, other spaces like that? The other thing that I think is really important is if we lean into providing fact-based and non-judgmental education. You know, I think some of the other parts of this survey that we saw that was really interesting is that, you know, a lot of our folks like knew how and when to give Narcan, but 40% did not know how to administer Narcan. And we think Narcan is something that is super familiar and most people know. The answer is that they don't. You know, I saw Kat Donnelly pop on. Kat is an incredible NP who does street outreach through Healthcare for the Homeless in St. Paul, and she's been doing a lot of outreach on the train. And when the folks on the train are reversing overdoses, they think you have to keep somebody's hands over their heads. It's something that they really are convinced is a huge part of an opiate overdose reversal. Why? We don't know. We've been trying to figure it out. But, you know, like really making sure that there's a lot of fact-based education, nothing related to shame. And also, one of the things too is there's still a lot of myths around who and when and where and how we need Narcan. I know a lot of folks are stimulant users and they'll be like, no, I don't F with that fentanyl stuff, so I don't need to carry it. And really trying to not provide any sort of fear-based education, but education around like what the drug supply looks like and how it evolves and changes. The other thing too is that a lot of folks really do feel like they have used drugs that have been cut with fentanyl without their knowledge. You know, 60% of people are saying yes. And so really trying to promote agency in regards to who are you buying from? Are they using their own stuff? Are you able to have conversations? Do you have access to fentanyl test strips? And a lot of my folks who are unsheltered will often say like, you know, at this point, I just expect it. So how are we encouraging them to keep their body as safe as possible? You know, how are we providing access to nutrition and talks about hydration, things to keep them physically healthy that will help, as well as just prioritizing things like sleep. Part of this is so that they can make decisions that are not necessarily impacted by withdrawal in regards to their drug use, but also just, you know, really trying to say to people, this is how you stay safe, low and slow with that first batch. And reminding people that we absolutely and deeply care about them. So all of the different things, you know, what I've been trying to push for treatment providers, and I think Gina and I as LADCs have been trying this for a long time, is making sure that treatment now includes access to fact-based drug education in regards to if people slip. You know, it's not a situation where, you know, we're saying you're going to like have a recurrence of use, but we know that the highest risk of mortality from overdose is after being released from compulsory care. So folks that are being forced to go to treatment, how do we make sure that we're keeping them alive? And having really, I guess, necessary, and I don't even want to say radical, because I don't think this is a radical conversation, but a conversation that truly says, hey, I see you. I care about you, and I know about the situation that you might have to go back to. So let's make sure that we are keeping you safe when you get out of treatment and connecting. So that's the end of our presentation. This is our contact information, but we definitely have time to take a few questions, I think people want to ask. I see your hand, Elise. Go for it.
Tell me about this stipend thing. What is a stipend in your state?
So the stipend that we had was actually from a CDC grant. And so we were able to give people gift cards for participating in a series of focus groups and surveys, we actually created a pamphlet that is going to be distributed. I can actually share the pamphlet too, if we want. This is the pamphlet we created that is going to be attached. And so it's a guide that was written by unsheltered drug users for other drug users and how they keep themselves safe. So one of the things that, you know, as a person who has, you know, not used drugs in the past, I'm very transparent about that. There's certain things that, you know, I just don't know. And so, for instance, a lot of our clients are saying that when they taste fentanyl, there's a slight sweet taste. There's actually a series of peer-reviewed articles that talked about that, you know, folks who use drugs have been saying fentanyl has a taste and a smell. But obviously, you know, in terms of peer-reviewed articles, we're not seeing that. And I don't know if you've all seen those delightful billboards on 94 that are like, it's tasteless, it's smellless, you don't know what you're taking. Folks who use drugs actually say that there is a chance that you actually can smell and taste it. Tranq, obviously xylazine is something that's infiltrating our drug supply. Folks are saying that kind of smells like gasoline. And so this is some of the education that we were able to get through that survey where folks were provided a stipend. So unfortunately, the stipends are no longer available, but it was more just how do we keep you safe in the community. And then the other thing that I want to highlight about this is in terms of, we actually found a free overdose grief support group by Survivor Resources in St. Paul, which is something that I hadn't seen before. So folks can enroll in an anonymous support group for grieving individuals that they've lost due to drug overdose. So it's a cool service. Does anyone have another question?
I think Kyle, if you don't mind putting your contact info back up on the screen.
Oh yeah, sure.
Someone's requesting that, and I'll email out that information to everybody and also the pamphlet so that you all have that.
Mhm. Mhm. Sorry, I couldn't find I had a like PowerPoint moment. I was like, how do I share a screen again? It's been one of those days. There's a lot of folks I see here from Hennepin County, and I just want to like stress that Gina is a joy to collaborate with in Ramsey County, and everyone should. If you have folks that are hopping over there for shelter services.
Yes, please reach out. Love to collaborate. Love to know who's coming our way too. It's helpful. We can look for people.
Mm-hmm.
Does anybody have any other questions or comments? I have still a few minutes.
I have a quick question. Do you have sites where people can actually test their drugs? Because the fentanyl test strips just really tells you if there's fentanyl. But do you know what I'm saying? There's these machines. I know we're purchasing them in New Mexico and going to have some sites. I forget what they're called again. I apologize.
So unfortunately in Minnesota, we don't right now. I mean, I think the closest full spectrum testing we have is in Chicago through the Chicago Recovery Alliance. I know that I've proposed in a couple different projects, we're looking at actually sending drugs to the University of North Carolina, I believe has a drug testing lab. The unfortunate thing is most of our toxicology data about the drug supply is really coming from drug screens that are actually administered in the ER. And so, you know, I think this is one of those things where we know a lot of folks who are using don't go to the ER in regards to an overdose because it feels unsafe for so many different reasons. And so, you know, I think this is a project that a number of folks are attempting to work on. in terms of getting access to full spectrum drug testing. We had like a really exciting legislative year in 2023 in terms of the decriminalization of paraphernalia. I don't know if anyone else here, because there's a lot of folks from the Syringe Exchange Network that might have more updated information on where we are with full spectrum testing.
Yeah, she's talking about what I'm sorry, the FTIR machines. That's
Mhm.
what we're purchasing, and they're going to be in sites that, provide like harm reduction, like some of our different centers where people would go, actually, not hospital-based or emergency.
Yes.
Yeah, that's what I was referring to. So
We don't have any now. I think there's hope that it will come soon.
And it looks like in the chat, a couple people said there's some things coming soon.
Yeah.
So that's exciting.
Yeah, I can chime in about that. DHS was able to front some funding for a few syringe services programs around the state to purchase those machines. And so I think right now folks are in the process of getting staff trained, because it requires quite a bit of staff training to do those point of service testing programs. But I would imagine within the next year, those sites will be up and running for people who use drugs to, at the point of like syringe services, be able to test their supply.
Yeah. And I was going to call you out, but I wanted to allow you to engage voluntarily. I was like, Anna knows, probably.
No worries. Thanks, Kyle.
There's another comment, it looks like in the chat from Kat, recommend xylazine test strips if you're not already using them.
And, in regards to the survey, most of our folks, at least at, spring of 2023, so it's already a year later, had not heard of Trank. So that's definitely something that really is important in regards to education. I currently work at the Wilder Foundation, and we're still really trying to get a handle on educating folks who are Hmong and Karen, because so many of those resources are really English based. So how are we able to reach out cross-culturally and provide culturally specific and language specific resources in regards to that? And that's a project that we're actively working on right now.
I have a quick question. My name is Valerie, and I'm an LADC at HCMC Addiction Medicine. Occasionally we have, I work in inpatient consultant. Occasionally we have people here. We had not too long ago a Karen individual here. And would you be the person to reach out at Wilder for
treatment support?
Yeah.
I can actually, I'll pop our intake coordinator as email into the chat. The other thing that's great is she is Karen and a Karen speaker. So
Beautiful.
that individual would be better served by talking to May Toon. But we are running 2 Karen groups right now at Wilder. And we also have a series of outreach programs for Karen youth in the St. Paul Public Schools that we are piloting.
That's great. Thank you. And thank you for this presentation and for pointing out that people need to check their own feelings about what it means to be unhoused and using substances. Personally, I think that I like to think about what it would be like. I personally could not live unhoused and not turn to substances for what feels like help. So it's not always even addiction that pushes that along, it's survival.
Yeah, absolutely. I mean, I think about this all the time. All the time. And I just popped May's email in the chat for everyone. So Wilder also is able to serve any language in our IOP. We are we actually have a multilingual group right now that has 6 different interpreters in it, which obviously is not ideal, but we're one of the only spaces in the state of Minnesota that will provide interpreters for substance use treatment. So we have Nepali, Karen, Hmong, we have someone who speaks Oromo as well as in our program, and 2 Swahili speakers as well. So, you know, we are trying our best, and we are actually really actively trying to push, because technically, if you accept Medicaid, you have to provide interpreter services for substance use treatment. But, you know, obviously there's some gaps, and so we're really trying to push that.
Not sure if you've seen, there's a question from Elise. Are you seeing ISO and gas station heroin? And then Ren commented, seen some ISO in Minnesota, not much in the way of tianeptine. I don't know if that's.
We, at least in the community I'm spending most of my time with right now in St. Paul, I haven't seen it yet. It doesn't mean that it's not here. You know, I often feel like we'll become more aware of a substance in Minneapolis, and then it'll kind of trickle its way east. So.
Yeah, that would be my answer as well. And it often, where I work, I don't always get to know what people are using, because they're not always sure what they're using, and that comes out a little bit later.
All right, well, it looks like we're at time, unless anyone has any quick thought. But I just want to say thank you so much, Gina and Kyle, for being here today. It was an excellent presentation. We really think all enjoyed it. So thank you so much for the work that you're doing.
Yeah, thank you so much for hosting us. It was great to connect with all of you.
And feel free to reach out. I think one of the things that Gina and I both believe is we're only as good as our shared expertise. And so always want to support folks. And if we don't know the answer in St. Paul, we normally can find a way for someone who does. But yeah. Bye, team.
Thanks, everybody. Next ECHO is March 20th. Mariah Wilberg will be here talking to us about U equals U. So I hope you can join us again. Have a good day.